Thank you, everybody, for coming to this conference. Garfunkel Wild certainly did a great job. I can't imagine all the challenges they had having to pull together a remote conference. I think it's everybody's sincere hope that next year will not be that. But very happy to be here and to bring to you the topic, what facilities should be doing with renewed OSHA enforcement. And with that, what makes a good panel for these types of discussions? At the risk of sounding biased, I think we've absolutely pulled together an excellent panel for today. We have Sal Puccio from Garfunkel Wild and my colleague, Todd McDonagh from Healthcare Compliance Network. And what I believe gives everybody their qualifications is throughout the years, and I'll get into that a little bit more, we've actually gone toe to toe with OSHA, defending our clients, putting them in a defendable position, and also trying to help them proactively as well, and then post audit. So we're going to get into some of that. One thing I would say that's kind of a conspicuous absence of today is we did try to get OSHA here for this presentation. People that we've worked with before, and sort of at the last minute they said, no, we can't be on this because this is a for-profit entity or something like that. And by the way, I know Garfunkel Wild, being very generous, has put this on at no charge to anybody. And in the past, I've sat on panels like this multiple times with OIG, CMS, FBI, Office for Civil Rights, the list goes on and on and on, at seminars just like this. So it's interesting that they didn't show up, and a little disappointed on that. I got to be careful about what I say because we'll be going toe to toe with them down the road, I'm sure. But they did have the opportunity to reach out to hundreds of ASC and other healthcare organizations, and kind of think they dropped the ball on that a little bit. But looking forward to doing the presentation. Well, getting used to my clicker here. So OSHA, just a quick history while we get into some of the real case scenarios, which I think will be helpful to the audience. It started out in 1970 as the Occupational Safety and Health Act, and since the last letter has changed to administration. But OSHA came into healthcare in around 90-91, and interestingly enough, that's when we started our company. We started as an OSHA compliance company at that point for dental offices. And that was, you may or may not remember, when Kimberly Bergalis, a young woman from Florida, said she got AIDS from her dentist. Turned out a couple years later, after they figured out that may have not been the case, but the dam was open. OSHA entered healthcare with bloodborne pathogens, HAZCOM, and all that other stuff. And interestingly enough, they were obviously always involved in industry, big agriculture, construction, steel toes and safety glasses, and they kind of traded that in or expanded their services to surgical gloves and sterilization units and things like that. So that's where we are now. And it's interesting with COVID coming along, how similar it is, mostly the uncertainty, nobody knowing what they're doing. It's interesting how similar it was back in the early 90s, and how really not much has changed. Universal precautions is now standard precautions. They want you to write up your documentation, train your employees, look at the physical aspects of your facility, and make sure that you are providing a safe workplace for your employees. That's really their noble goal, which is noble, to make sure they're providing a safe work site for all of their employees. Of course, that spills over to patients and vendors and delivery people and all that stuff, but it really is designed for the employees. And as much as I looked at this, we used to go off what we called the AIM philosophy, which still works. It stands for assess, implement, and maintain. And that's kind of how you want to go about your program. But since then, the OIG has come up with the 7 elements of compliance. But in New York, being that we're in New York always has something special. They added one for the 8 elements of compliance. And what I always do is try and come up with acronyms to help myself and my clients remember what that is. And we came up with ICE Racer, and that stands for, implement your program, which is essentially write up your policies, pull together your program, all the compliance forms, all the paperwork, all of that stuff. Appoint a compliance officer. And again, this works perfectly for COVID and OSHA or just general straightforward compliance or HIPAA or anything like that. Education is really important. I'm not going to get into every single one. People give 5-day seminars on just these 8 elements. Clearly, we're not going to do that today. Responding promptly. Have something set up in your organization where if somebody does report to you that there's an issue or there's not enough personal protective equipment or whatever, show that you respond and that going forward you're on top of it. Audit, you almost can't audit enough. You want to keep going back and making sure that everything you put in place is in fact in place and that you're validating your compliance all the time. Communication, that's simply, again, being able to report, having a hotline and things like that. Enforcing standards, and that is, if there is a problem and you detect it, you've got to show that you've done something about it. So you want to have that written up as well. And the 8th, which actually is not just indigenous to New York, that should be for everybody. It's retaliate. It should actually be non-retaliation. It's not how to retaliate. It's that there should be no retaliation. If people bring up an issue they see, you can't all of a sudden give them the weekend shifts and the night shifts. That is, there's lots of forms of retaliation. So that's it for the 8 elements. And I'm really happy to turn this over to Sal and Todd, who are going to go a little bit more into OSHA and what's happening in some real case scenarios. And I may pop in from time to time with some comments or questions. But go ahead, gentlemen.
Thank you very much, Wiks, and welcome to everybody. New attendees and repeat attendees. It is unfortunate that we're not in person this year. I know the firm Garfunkel, while we always do a great job putting on a good event somewhere in Manhattan for everybody, something we certainly look forward to and look forward to seeing all our attendees join us and our vendors and speakers as well. But I think this is a great alternative. I've done a few of these webinar presentations and have gotten some very good feedback. And in this particular time and with the pandemic, there's always new topics that come up at these conferences. And as Wiks pointed out, right now, OSHA is a little bit all over the place and putting into place really enforcement of what they view as existing regulations. We're seeing it a little bit differently on the defense side, where we're representing you, the healthcare providers, and ASCs in particular. Some can interpret this to be enforcement of new regulations or a new interpretation of an existing regulation, if you follow my drift, meaning that, yes, there are certain protocols and regulations that are in place, but we've never seen OSHA expand it to the level that they have. And, the slide that we have up now just talks about the high volume of investigations that are ongoing by OSHA and the serious number of fines. And we can have a very long discussion about the politics behind this and why is it happening and why are certain industries, in particular healthcare, being targeted. But the bottom line is we are starting to see now a pattern develop within these OSHA investigations, where they're coming from, what they're targeting, and what the responses need to be. And on the back end, how do you deal with any violations or citations you may receive? So that's going to be the focus here. You can see on here what we're talking about, and I'll get us to the next slide, where some of the main areas that I'm seeing as representing healthcare providers, and I'm in the litigation and employment group. and we focus a lot on employment and in particular employment safety as it relates to OSHA as well as part of that. And I can't tell you, you know, in the past few years, we handle a handful of cases with OSHA. A lot of times things you can deal with internally, and you contact us as outside counsel to give a little bit of guidance. What should we be reporting? How should we be handling this? Is this really an issue? I have close to a dozen cases now that are active related to OSHA that deal exclusively with the pandemic and response to the pandemic. And most of those issues relate to having a respiratory program in place and compliance with that program, and the reporting and recording of work-related COVID illnesses. So we're going to take these two and we're going to pull them apart a little bit and talk about what's there. And on the back end, Todd is going to talk about some real case examples that he's handled, and I'll probably jump in as well to talk about some of the issues that we've seen. We do encourage questions, you know, during the live session. You can write them in. If for some reason your question does not get answered during that period of time, please feel free, shoot us an email. We'll collectively get together. Either one of us will shoot you a response, maybe all three, we might collaborate, but we definitely want to engage. And we'll touch on a little bit more. I think in this particular setting where things are so, you know, transient in terms of the movement from OSHA, from compliance, from the pandemic itself, the disease itself, you have to stay up to date. So there's constant change that we all need to focus on. And just remind you of that as if you get hit with an investigation or a question, what's the best way to handle it? So with respect to the respiratory program, you know, there's a bit of a dispute as to whether or not all healthcare facilities need to maintain this. Certainly hospitals would. So we would lean towards, in our discussions, recommending that an ambulatory surgery center should have a written respiratory program in place. The typical requirements for this related to when there were certain treatments that were going to be related to aerosol medications that would be issued, pulmonary function testing, and I'm reading from some of the OSHA sites themselves, endotracheal intubation, tracheotomy care, cardiopulmonary resuscitation. Those are just a couple of the type of examples of instances when respiratory programs would be required. What we've argued to OSHA is, you know, usually your respiratory program you see when they're in an engineering type setting, a mechanical setting, a construction setting, removal of asbestos, things like that. Healthcare, it's more about the airborne particles that could be relevant. Tuberculosis is a great example. If you're going to be treating patients with TB, you must have a respiratory program in place. We've heard from a number of clients that, well, we don't do that kind of treatment. That's not something we focus on. That's if any individual came to us with any of these types of signs and symptoms, they'd immediately be discharged. They wouldn't be seen. They'd go to a hospital where they could get the proper care. But again, as a backstop, what we can tell you is OSHA is requiring that just about all healthcare facilities, and we've made the arguments, must have this respiratory program in place. The program needs to be written. You have to have the documentation. Just a couple of quick snippets about what's going to be in that written policy. You'd have to identify an administrator. You'd have to put in place what the storage, use, and disposal will be of the respirators. And you'd also have to include what the training would be and evaluations that we'll talk about next, as well as your record keeping. The next step is, once you have that policy in place, OSHA is looking to confirm that you followed what's required in the written policy itself. And the two topics that they seem to be ultra focused on are, number one, medical evaluations, and number two, the fit testing requirements and training. So for a medical evaluation, the long and short of it is, in order to use a respirator, and I'm going to pause here for a minute because there's a bit of confusion in terms of the use of some terms. We've heard the use of an N95 mask probably. OSHA defines an N95 mask as a respirator, not as a face mask or a surgical mask. So use of an N95 mask invokes these policies. It means you have to have the policy, you're going to have the evaluation, and have to have the fit testing requirements. Unless there's, and I think Todd will talk about it in the back end a little bit, there's a voluntary use of the N95 mask that we could talk about separately. But if it's mandatory in your facility, if you're giving your staff N95s to use for certain procedures, you must comply with these requirements. You know, typically, respirator, you think of someone with the big mask and the ventilation systems that they're wearing, they almost look like an alien, right? That's not what we're talking about. It's the straight N95 mask the doctors and nurses might be wearing in your facilities. So you'd have to do medical evaluation. You're going to basically test to make sure the individual you're giving that respirator is medically cleared to wear it. The respirators, of course, might make breathing a little difficult, and that's the objective, right? Because we don't want particles to get in, and it's supposed to filter those out. Some cases where you might not qualify to wear the respirator if you have heart disease or lung disease or suffer from claustrophobia. Those are some examples that OSHA themselves give. Once you check that box and you have your medical evaluations in place, now you have to fit test individuals. And that becomes extremely complex. A lot of times you're looking to get outside vendors. During the pandemic, it was near impossible to get anybody. But now, being 6-8 months removed, you're not going to have the excuse of, well, I couldn't do the fit testing, I couldn't do the medical evaluation, it was too hard. So make sure you're going to adhere to the fit testing requirements. One thing we have seen is that with respect to fit testing, OSHA did relax the standard a little bit to be a good faith requirement because the shortages that were going on with respect to the PPE and respirators in particular. Moving on, the next topic that we're talking about where OSHA is targeting healthcare facilities are your reporting and record keeping obligations. And what does that mean? Well, you see I have listed here OSHA 300 logs and then reported of COVID-related deaths. So we have seen in several instances, this is the jumping off point for an OSHA investigation. Giving you some real life examples, case comes in where a family member goes to OSHA and says, hey, just want to let you know my relative died of COVID and worked at XYZ healthcare facility. OSHA opens up an investigation saying, you never told us so died of COVID. You had an obligation. That one discrete alleged violation then turns into a series of, I've gotten inquiries of up to 36 to 40 questions. Did you have this? Did you have that? Where's this? Where's that? After you answer all those questions, then they start coming in and interviewing your staff. They will call them at the office. They will call them on their personal cell phones. They'll call them on nights and weekends. So, and then they're asking the staff questions. Well, did you get training? Were you fit tested? Did you have a medical evaluation? Was that N95 mask mandatory? Where are they keeping them? Do they have enough? Are they stored? So they're going to go through all of these questions, the litany of questions, and make it very difficult. So again, the record keeping is where it starts, but then it tracks back to that respiratory program very quickly. And the issue I'm sure you're all thinking about right now, and you've probably already crossed it in the course of back up and running and operating your AC, is how do I know if it's reportable? What are the standards? Why would I have to report something? I don't know if it occurred in the workplace, if that's where the person contracted COVID. And you're thinking along the right lines. Even OSHA had to make some revisions to their policies, generally because they were a little bit too broad. So they narrowed them down to recognize that it is difficult to trace and track and keep an eye on things. So it's certainly something you're going to have to address. You're going to have to view and deal with in real time. You can't just assume it wasn't work related. I had what we felt was an absolutely great defense. Individual worked outside our healthcare facility, had a second job at a grocery store in Queens during the pandemic and in one of the high incident rate areas in Queens, and was witnessed to me not wearing a mask, working a register. So it was pretty clear in that case that we could say the transmission occurred outside our facility. It was not work related. We had evidence, we had backup, we had independent. And what the OSHA area director turned around and said to me was, well, I looked at your other logs, the list of patients, employees rather, that have tested positive, and you have 20 out of 20 that weren't reported. I find it hard to believe that 20 individuals all got COVID and not one of them was work related. So they were investigating one case, and it turned into them now looking at 20, and they cited us because we didn't report any one of those 20. They wanted an independent assessment of each of the 20. It's near impossible. So you have your work cut out for you, but here at Garfunkel and Todd and Wiks, healthcare compliance, that's what we're now looking at, and we're addressing these things and getting them head on. So this next slide, these are just some of the compliance program requirements. And I'm taking this directly from citations that OSHA has been issuing. These are where they're coming in saying, hey, you didn't have that mandatory respiratory protection program in place, violation, and a fine. Fines, by the way, are based upon the number of employees you have. We're still challenging that too, but it's not the number of employees that are required to wear the respirators, it's total number. And you'll see these others, you'll have the slide deck, but these are the other violations that we're seeing. So take a look at these, make sure your compliance programs are up to date with these, and let us know if you have any questions. You know, on the reporting, again, this has been one of the most, you know, argued over issue, because everybody I speak to says wasn't work related. How do I know it was work related? I don't even know if it was COVID. They just went out for a few weeks. So there's a lot of factors that go into play here. We don't have time in this 45-minute program to talk about all of them. There are certain criteria, though, that have to be met in order for it to be either reportable or recordable. There's a slight difference there. We're going to tell OSHA. One I have listed here because they've cited several healthcare providers recently is when you learn of a death, that's reportable. You have to call OSHA within 8 hours of you learning of that death and tell them we had an individual who died of COVID. Again, that presumes that it was contracted at work. You have to do that analysis. So you have a short time frame to do that entire analysis and report. Again, it's 8 hours from when you find out, not the date of death, but it becomes a very difficult trend. So these are just, you know, some issues that we want to look into. The main thing I'll just point out is the standard now is it more likely than not that it was work related? And is there an alternative explanation that you could point to? If you can find an alternative explanation, went to a super spreader event, a wedding out in Suffolk County. We've seen 2 of them now in the past 2 weeks. At that wedding, safe to say, it wasn't at the office. It wasn't at the healthcare facility, or somewhere else. So I just listed some guidance for you guys to take a look at. Hopefully you can click on these. If not, let us know. We'll be happy to send you a PowerPoint that you can access and click on, and be available for other questions. But at this point in time, I want to turn it over to Todd so he can go through some of his case examples. And like I said, I'll probably be chirping in a bit as well. Good practice tips. Most of them we've covered. The first one I just wanted, this is a little bit of an add-on, is have your return to work policy in place. That's something else that we are seeing OSHA focusing on. Were you cleaning, disinfecting, social distancing, partitions? Are all those things in place? If not, that's another area where OSHA is targeting a bit. We've been very fortunate here. You know, we've got out ahead of it with advising our clients through client alerts and programs where we're seeing most people have some kind of program in place. If you don't, strongly recommend it. It's not all that hard to put together. You can do a quick training too, but it's well worth it. And if you can turn that over to OSHA, it's going to save you a heck of a lot of trouble in the long run.
Thanks, Sal. You know, it's interesting when you put together a couple of heads of individuals who are in the compliance space and you start to exchange some of the stories, you realize that there's the elements that come through in terms of the cases are tremendously diverse. Having been a nursing home administrator in a previous life, a lot of what's occurring now feels very similar to some of the stuff that I experienced as a nursing home administrator, where they were very much targeted on a particular area, and in those cases, they would use their reporting information, the stats that they would take from those OSHA 300 logs, and determine potential areas that they would go after in the upcoming year. In this particular case, the nature of the stories that Sal and Wiks and I swapped were really interesting from the perspective of the diversity of one, how each of these individual groups sort of went about these, and as Sal will discuss, that's very different from our experience, that the outcomes were less punitive in our side and much more punitive for Sal's side. And, you know, it goes to show, and I know that some of these examples will not necessarily target the ASCs, but they, being OSHA, bundle everybody into healthcare organizations. And sort of the predominant element that's come through, and Sal, you can speak to this as well, but what we were seeing from the cases that we had were complaints literally directly coming from an employee who has been whooped up over the last 6 months by all the news that they've been digesting and all the information that they're getting, and one day they come in and are feeling as though their employer is not necessarily taking the necessary steps to keep them safe. All it takes is that one instance of them picking up a phone, dropping a letter, whatever they need to do, and that lands on OSHA's desk, and by virtue of their mandate as a regulatory body, they've got to investigate it. They've got to put out their information to make sure that it's either warranted or unwarranted. And in the two cases that we identified here, the actual follow-through realized that these two groups were in fact doing what was necessary, and this is very new kind of for the healthcare world. Maybe not so much in the hospital world or in the nursing home world, but certainly in the physician practice and in the outpatient environments. This is not dealing with fit testing is not something that was regular, standard. There across all of what we've seen that's occurred through this period of the public health emergency, OSHA hasn't really changed all that much in terms of their own standards. They've put guidance out there and pointed back to the CDC, but it's been standard stock that you have to maintain the general duty clause, and PPE elements haven't changed. How you're treating medical waste hasn't changed. Standard precautions hasn't changed. There's just been the necessity to have to ramp up some of these things and reincorporate that into your groups and make sure that your people, one, are well articulated. It's interesting to listen to Sal, and it's been very interesting to listen to some of his follow through on on his clients, and that OSHA, we like to believe that OSHA is not out there in a position to kind of trip you up. But as a nursing home administrator, once OSHA's in your facility and you give them an idea of being in their facility, their eyes just aren't necessarily focused on the particular complaint itself. All of a sudden, their eyes expand across the whole organization. So this brings to light just not only the fact that you've got to be sort of, mindful of the COVID elements, but you also have to be getting into the education and making sure your people are doing that. And we've found with our clients that we've given guidance to them to say, during your weekly meetings or during your monthly meetings or whatever it is. And we found that a lot of our clients early on, when finally the states were letting down their guard and the practices were starting to bring people back in, although most of them were treating folks telemedicine wise, but these groups needed to really ensure that they were incorporating this information to their employees, but also to the patients, because obviously the energy out there has been, quite accelerated in terms of what's being said and what's coming through from the media side. But just pointing back into these examples, we had a ear, nose, and throat group that had been identified by an employee, and the three items here, which I'm not going to read through, were what was the complaint. And the nature of these complaints was the employee not feeling as though the group had done what was necessary. And as a function of what we were doing with our clients is that we were going on site, and which is something that we typically will do on an annual basis for OSHA surveys, is to go on site to validate that there's elements that the group is doing those things that are related to general duty cause. And in regards to COVID, is were they really taking a much more measured extent to the cleaning aspects, to the educating aspects, to the triaging of patients prior to them coming in, to the enforcement of PPE. If clients were actually bringing in COVID-related cases, did they have the right, the right things in place in terms of what Sal just talked about in the respiratory program, and that was all new information. Fortunately, In this particular case, after we sort of stepped in and got involved, it became very clear when we put our information in to OSHA that this group wasn't standing by themselves, and we'll probably talk to that a little bit more. And the nature of that gave this group the ability to put in information, feel comfortable that they had the right information, that they were doing the right thing. We validated that with the risk assessment. And in the capacity of that, OSHA gave them they closed it. What OSHA will do is after they've opened something, they've investigated, then they will go ahead and they'll close that case. You'll get a letter saying that, and then they move on. Similar to another group here, there's an OB group, OBGYN group. What was different about this one, and we had to kind of get into the mindset with OSHA a little bit, because when we were reporting back to them, you have to be very candid and obviously express exactly what you're doing. We weren't aware to the extent that when we were extending out to OSHA that the group was making available N95s. Now, they weren't doing that because they had a respiratory program. In fact, this group wasn't even treating anybody that had COVID. But they were dealing with the employees saying, well, you know, the best masks out there are these N95s, so you know those should be available to us as employees. Where really they don't need that, because the possibility of moving the particles that come out in terms that can be, you know, aren't for someone who's non-infectious, it can be handled with a surgical mask. But the practice was doing the right thing. They were trying to be considerate to their employees. And problem was that when we put that information in to the report back to OSHA, immediately OSHA jumped on it and said, well, where's your respiratory program? Which we in turn had to come back to say, they're not treating COVID patients. So in that capacity, this now has become a voluntary situation. And we learned from that aspect that you didn't necessarily hit the standard, but you were in an involuntary program. You had to reflect on Appendix D, which I think in Sal, you put some of that information in referencing some of those sites that people could go in and look at Appendix D.
Right. Yeah, it's part of those links.
So it's indicative of the fact that if you're sending in information, you have to be very clear about, you know, if that information is potentially going to raise the red flag at OSHA, you need to be prepared to come back to them. And we had to come back to them with the understanding that a program was being put in place. We got their people trained. The hospital stepped in to do the fit testing, which was great, and that's hopefully a scenario that a lot of doc groups can go through and rely on the hospital, because the fit testing aspect can be a challenge to be able to do in the medical evaluations. All those things are part and parcel, as Sal had spoken about. So just kind of pushing along here, again, this group ended up submitting their information. We came back with some subsequent information. And in this case, we actually had a law firm. Unfortunately, it wasn't Garfunkel Wild. Sorry, Sal. But again, it goes to show that we were prepared. We went in with a very cogent understanding of how we were treating the questions. And 24 hours later, after submitting all the information, they closed the case on that. But I'm going to flip that to Sal and have him go through his cases, because very, very different aspects.
So along the same lines, we had an issue where an inquiry was made, a complaint was made about, in this particular case, it was the passing of a physician that worked at a facility. And the initial inquiry, again, was, why didn't you report that on the OSHA 300, or why didn't you report that to us directly within 8 hours? That was quickly answered and addressed. We responded. But then it turned into the larger issue, just as Todd said, they wanted to see the respiratory program, they wanted to see written correspondence. And part of what we argued, but unfortunately in that case, we got involved as counsel a little bit later on. And while we were having a discussion, so part of the process is you go through the investigation, OSHA will issue a determination that's either going to be no violation or there'll be a violation. Then you have an opportunity to discuss that with the area director. If you're still unhappy, you can contest it. It's a form of an appeal and it'll go to an administrative law judge. So when I got involved and we were able to talk to the area director, one of the things we said was, okay, well, what is this citation for about medical evaluations and respiratory programs? The two individuals that you investigated us about, one that died and one who complained, they both had medical evaluations. We gave them to you. They both had fit tests done. We gave that to you. We met the requirements. I don't understand. One refused to do the evaluation, so we sent them home. The other did it and continued. They said, oh no, it wasn't those two, it was these other two. And I was dumbfounded because I said, well, we're talking about two people you identified. Now in the midst of this, you're shifting to two other people. Had you asked about those two other people, maybe we could have gotten you some documentation about what was involved or what their requirement was. And as we're learning, these individuals were a part of a dental group that was part of a larger practice, and they weren't working. They were doing clerical work. And the answer from OSHA is now, well, you gave them an N95, so you have to do the program and you have to do the training. I said, well, again, we're falling back into that voluntary context. So you have to be very careful, as Todd said, in terms of what information you're providing and how it will be interpreted on the other side. And I'm seeing this across the board. I've been on the phone with area directors out of New York, New Jersey, Long Island, and believe it or not, Puerto Rico. And everyone has a little bit of a different view, but all across the board, they're sticking to the company line that healthcare provider, you have to do these things. If you don't, it's going to be a violation. And the next example was just more of the same, in terms of the initial inquiry starting with respect to reporting of an illness or a death and turning into a bigger issue. The interesting point is bullet 3 on here. That's so we don't repeat ourselves. There was a heavy focus on contact tracing. And I made the argument up front that there's no way you can pin this down to our facility, just not possible. And they went through a litany of questions of what elevator did she ride? Who did she come in contact with? Were there any patients that she treated? And we kept saying she didn't treat patients. This individual who you're talking about didn't have contact with patients. Then they wanted to know if she had contact with anybody who had patients. What floor did she work on? So it was extreme level of detail that they were looking for. We answered everything correctly. And as Todd said, we had a very good outcome. They closed the case, no violation, because we demonstrated to them that this should not have been reportable. But again, they made us jump through hoops in order to get to that conclusion. So it's just very important to keep your eye on the ball, what OSHA is looking for, where they're going. I've a couple of times had to be a little more aggressive than we'd like to, because, as Wiks said early on, we have to deal with these folks on a regular basis. That said, I put my foot down a couple of times and said, you're going too far. Enough is enough. If you want something from me, put it in writing. In one case, they sent the subpoena, and I got to deal with an attorney out of the Department of Labor, the solicitor's office. I had a good experience there. We knew what we were giving. We knew what we were going to have to get, and it went. But the way the investigation itself was going, it required a little bit more aggressive action. So you'll have to balance that accordingly to determine when it's okay to turn over documentation and when it's enough to say, pump the brakes. You're going too far. This isn't what you're investigating. We're going to slow things down a bit because, again, I think it's a little bit unsettled, and you're trying to hit a moving target, and OSHA is trying to enforce a moving target on their end, and it's been difficult to manage and maintain.
Hey, Sal, it's Wiks. You bring up a good point. So when someone is first audited or there's going to be an audit, are you taking that through the mail? Through how are they notified? And how quickly should they respond? And what type of follow-up? Those are the questions I get a lot. I'm just curious.
It's been a combination of mail and phone calls, and I think that's because of just the circumstances that we're all living with right now, where there's not in-person investigations, in-person meetings. So we're getting a notice of investigation, a letter with a series of questions that assigns a investigator, and then that investigator will call right away and look to speak to people. And that's, so again, it's been a combination of letter writing or document writing. They will accept emails. We've been forwarding information along by email in terms of responses, but then there are the actual questions. We've scheduled several conference calls where you're going to meet and greet and talk with staff about particular issues.
And what's a reasonable turnaround? So you got the letter today, respond within 5 days, 10?
Yeah, OSHA's been giving about 10 days to 2 weeks max. They have not been very accommodating throughout this pandemic with extensions. If at all, you can get a couple of days. So you have about a week, 2 weeks absolute max. It's really 10 days, business days I'm talking, to put your responses together. What I found to be very helpful is put together those documents that you have right away and get them out. Some things are going to be at your fingertips, you can get out. If you have a respiratory program in place, quick, turn it out, get it out the door. That's going to set the tone for the rest of that investigation right off the bat. If you have some other information that's very helpful in terms of logs that you may have kept, again, not reportable, but recording. If you recorded on an OSHA 300 and you're keeping that, send that right away. Or if you did the analysis why it's not relevant, why it wasn't work related. Jane got it because she worked in the community. She went to a super spreader event. She traveled to Florida. Get that information out there right away. Day 2, day 3 from the response. That'll give you some more time on the back end. Where I pushed it to 10, 14 days, we've gotten some arguments and we've gotten hit with some subpoenas. But I think, in this day and age, but when we're going back, 3, 4 months, it was impossible to turn something around in 10 days. You just couldn't do it. There were too many other things. Now I think things are settled enough so you can respond.
Yeah, Sal makes a good point there, Wiks, in regards to the preparation, and obviously COVID has sort of changed the dynamic of in-person stuff. But the one thing I can say, having sort of sat in front of OSHA inspectors who walked into facilities unannounced, is the ability for you to suddenly show up 10 minutes later with your safety logs, your policies and procedures, your training logs, the information that shows that you've done your OSHA 300 logs. They come from being way up here. My camera's not going to get this because they got a mandate, and then they go way down here when you show up because they know that you've got your information together, and I can't stress that enough.
Yeah, gotcha. Is it too early to ask you guys, okay, you've been through the whole audit, everything. What's the follow-up? What's the chance of them re-auditing? I mean, well, again, I'll ask, is it too early? If it's not, what is the chance of the follow-up?
Well, I would say, I mean, certainly in the cases that we've seen, there was a little give and take, but once you are meeting those daily, those requirements, and they close the book, there is no more follow-up, and you don't need to feel as though all of a sudden you've got a bullseye on you because they've got enough fish to go into the barrel and shoot at to keep their process moving along.
I bet. Yep. Okay.
I would join that way. What I am seeing is that in these informal conferences that we're hosting or the challenges that we're making, OSHA is still focused and has their eye on abatement. And even though we don't agree maybe that the respiratory program was required or that the reporting was required in certain instances, we're demonstrating that abatement to kind of clear that hurdle, and that's been very helpful. The only situation I think where you might have to be concerned with the reoccurring investigation or follow-up or audit is when someone's complaining about workplace procedures. You didn't have enough masks, you were letting people run around without masks, you didn't have partitions, no social distancing, you didn't have that return to work policy that I mentioned earlier. That is going to be a potential for reoccurring because if you didn't report a death, it happened. Unless you have another death that you don't report, that's a separate incident though. But it's those other issues that Todd was speaking to that I could see be recurring that you need to focus on. So don't just put your head in the sand. You got a violation, you're going to pay a $10,000 fine. Fix those issues.
Great. We're pretty much right up at 45 minutes. I don't know if you guys have any parting comments or we can just wait till the 18th for questions from the field.
I do just want to take a quick look at this slide just because the one thing that Sal and I also realized as we were exchanging notes is that the segment of questions across any incident is the same. And the first three here kind of get into risk assessment, which drew a question mark from our side, because when you go back into the regs, there's guidance around risk assessment, but then talking to an actual OSHA representative, they really couldn't define what they were looking for. And then when I was explaining to them what we were doing with our clients, he said, without having the ability to validate it, but it sounds as though what you guys are doing is more than what we would expect from a risk assessment. And then the other piece around the SDSs, and this, I'm not sure this still is the case, but clearly back in the early days here, there was a lot of an ability to get what you needed from your standard supplies, and you had to rely on your manufacturer, your reps to get you something that was going to be EPA approved. You know, make sure that you get the documentation there, because they're going to want it. That they are going to uncover the things necessary to make sure that if you've got programs in place and you're utilizing various systems around your cleaning and your disinfecting, that those systems are clearly warranted and effective.
That's all for me. Thank you guys all for your attendance, and look forward to speaking with you or engaging in emails or messaging back and forth on the program.